Hello, I'm Dr. Jeremy Smith. Thank you for joining me tonight. I'm an orthopedic spine surgeon and chief of spine surgery at Hoag Orthopedic Institute. Tonight I'm going to be talking about minimally invasive treatment options for spine afflictions, and we'll have some time for some questions at the end. I'll go over an outline to talk a little bit about an orthopedic versus a neurosurgeon for spine surgery. We'll talk about some common and basic spinal pathologies that we most commonly see in our offices. And then we'll talk about some of the newer minimally invasive options for these conditions. To start off, a spine surgeon traditionally has been trained in neurosurgery versus orthopedic surgery. I personally have trained in orthopedic as an orthopedic surgeon in residency. Oftentimes your spine surgeon will have training in one or the other. Traditionally, it's thought that the neurosurgeon takes care of the nerves and the orthopedic surgeon takes care of the bones. And nowadays, it really is more, we have dedicated training within spine. So it's important when seeing a spine surgeon that they have dedicated training in spine. I also would prefer a spine surgeon had their practice primarily in spine. So it's an important point, and the common traditional thought really doesn't exist as it once did, as we have training really in both neurosurgery and orthopedics in a combined or dedicated fellowship into the spine. So minimally invasive surgery, why do we perform it? We really can nowadays perform quite larger surgeries, where in the past it would be larger incisions, more blood loss, greater hospital stay. It really has to do with soft tissue manipulation, soft tissue disruption. We're able to do these surgeries through smaller incisions and have less blood loss. Certainly it makes recovery a lot easier. And so I'll talk about some of these options. So the diagnosis that we'll go over, probably the most common one you've heard about, is sciatica, lumbar spinal stenosis, cervical arthritis, and scoliosis. So sciatica is really when a patient presents with numbness, tingling, a burning pain that usually happens down one extremity. When we think of it in the sciatic nerve distribution, we think of the buttock, back of the leg. It's commonly associated with numbness, tingling, and sometimes weakness. It's usually in a very distinct pattern, and the most common pattern includes the distribution of the nerve that's being pinched. So we usually see it in the L5 or S1, and that would be in the buttock, posterior or back of the thigh, and back of the calf, or the side of the thigh, side of the leg, and into the top of the foot. It generally occurs in younger age groups. We most commonly see the age group from 20 to about 50 years old. It's usually a very acute onset. A lot of times it'd be something very trivial, like turning abruptly to one side, a cough or a sneeze. It doesn't always have to happen with a fall or a traumatic situation. Generally, I see these patients in my office, and when I walk in the room, they can't sit down, so they're either standing or laying on the bed. I can almost make the diagnosis just by seeing them. It's very difficult when they sit down. It puts tension on that nerve, and it recreates the symptoms. So it's commonly diagnosed. Well, the most common study that really confirms the diagnosis is an MRI scan. We can see a disc that's herniated. If we think of the disc almost like a jelly donut, and it's that cushion segment between each of the vertebrae within the spine, there's that hard outer crust and then the jelly material inside. And what can happen is that hard outer crust is breached, or there's a hole, and a piece of that jelly material sits outside and can press or push a nerve, and that generally can happen very suddenly. X-rays are commonly used to look at the bony anatomy, but the MRI is really definitively gives the diagnosis. It's something that, believe it or not, most commonly heals on its own. The statistics I tell my patients when it happens is that 75% of the time it heals really with time, and usually it's within the first 3 months. So oftentimes, as long as there isn't a neurologic deficit, such as severe weakness, as long as there's no bladder and bowel function problems, as long as it's not severely disabling, we can try a conservative course of management. And that often involves anti-inflammatory medications. In the acute setting, we can treat with a taper of steroids, where we taper down over 5 to 10 days. In those situations when the patient's evaluated and really a basic course of anti-inflammatories don't work, we can try epidural steroid injections. Physical therapy helps strengthen the core muscle groups, certainly to help prevent future disc herniations and sciatica from happening. It can be very helpful. It often involves traction. So if all of those fail, and we usually give a generous trial of 6 to 12 weeks of conservative management strategies, sometimes 1 to 2 epidural steroid injections. If that's still not working, a surgery called a microdiscectomy or microdecompression can be performed. It's an outpatient surgery. The incision is 1 centimeter or 2, and we can use our tubular retractors or a small retractor system that allows us to really gain access to that disc herniation. Again, that jelly donut analogy, that piece of that jelly sitting on the nerve, we can actually use our tubes to find directly over the bone and see and remove that piece of jelly fragment that's pressing on the nerve. We really can release, and it's a pretty immediate and very gratifying surgery because the patient wakes up and their pain is gone. Generally, it's minimal blood loss, and again, it's an outpatient surgery. You can see the tubular retractor there. It was about the size of a quarter. That's an X-ray image just showing what we look at to help guide us down to the area. And based on our MRI and X-ray, it helps find exactly where that fragment is. And we can work through these tubular retractors and see very well. So that's just an example of the disc that we pull out after surgery. It's a large fragment, and that jelly material. And you can see the incision on the right is closed and looks very small. So when we use these less invasive tubular procedures, there really is, we use a muscle interval. We don't have to actually damage the muscle. That does result in less blood loss. The incisions, of course, can be smaller, and we really don't have to retract the tissues heavily, which can cause damage. One other benefit is that when we go through traditional approaches or larger incisions, those muscles really aren't the same. When we go in between the muscles, we can preserve their innervation, and those muscles can really return back to their normal function. So again, reduced pain, reduced narcotic pain medication requirement, and really a quicker return to function is the pros of this. One common type of surgery that we're seeing more often that's really geared towards very specific pathologies that we hear about more and more of recent is endoscopic spine surgery. And it's for the typical disc herniation, generally still the open small tubular surgery is the way to go. For some very specific and narrow criteria of patients, the endoscopic procedure is something that is even a little less invasive, but really must be performed by a surgeon who has extensive experience in endoscopic spine surgery. It's not as if every procedure, every pathology can be treated with the endoscope, but there are a narrow window where there's either bone spurs or small disc herniations in tight areas within the spine and the nerve tunnel that can be accessed well through the endoscopic spine surgery, where otherwise would require a very large open procedure. The next diagnosis I'll talk about is lumbar spinal stenosis. And stenosis essentially means narrowing. So if we look at our area for our nerves is generally about this big, and stenosis quite frankly is just less room. So stenosis can be caused by a number of factors. A disc herniation can be one of those factors. Probably the most common factor that we see in the spine that causes stenosis is arthritis. Arthritis of the joints, and what can happen when arthritis happens, those joints enlarge, they can form bone spurs. The ligaments surrounding those joints can inflame and enlarge. That combined with small disc herniations can create pinching or squeezing of the nerves, which we term as stenosis. Stenosis is quite the opposite of sciatica. It's actually easier to sit down. You feel relief. So when you're standing and walking and there's just a little bit more pinching on those nerves, it is actually reducing the blood flow to those nerves when you stand and walk, and then leaning forward or sitting down actually opens up just a little bit the area for those nerves, and it gives relief of the symptoms. So very commonly in patients, and this is generally an older population where the arthritis is more widespread, these patients will tell us that when they go to the grocery store and they feel that really they need to feel relief by leaning forward, or they cannot walk more than a block without having to sit down to relieve the symptoms. So it's a degenerative process, as I said. Some other potential causes include cysts that also are related to arthritis, and something called a spondylolisthesis, which is a fancy term for saying the vertebrae aren't aligned correctly, that there's actually a slippage of those vertebrae. So really a combination of all these factors can create stenosis. So again, as with the sciatica, conservative treatment often involves a combination of anti-inflammatory methods, including medication, sometimes topical anti-inflammatories. Physical therapy can help to strengthen the core and really teach the patient to accommodate the situation. Epidural steroid injections unfortunately don't work as well. When it's really a pressure phenomenon, it's less of an inflammation, they just work less. So it's really a pressure phenomenon that we're dealing with. So depending on the diagnosis, depending on what's causing the stenosis, really dictates a surgical approach. We again try a course of conservative measures. If there's a neurologic deficit, if it's non-responsive to these conservative modalities, if it's something that's debilitating and lessening the ability to function on a daily basis, then an option of surgery is generally proposed. Traditionally, we think about surgery for stenosis as a larger open surgery where we think the terms laminectomy. A laminectomy is a procedure that involves really releasing the bony arch that houses the nerves. Sometimes, depending on the degree of arthritis and whether there is an instability or spondylolisthesis, we sometimes have to do a fusion. So the traditional way of doing a fusion was a large open surgery, taking hip graft, certainly a morbid procedure. So, there are minimally invasive options that we certainly can do some of the tubular decompressing using the tubes to essentially shave those bone spurs away. Another option that I've used more recently is it's called an interlaminar stability device, or we call it it's a Coflex. It's a motion preservation device that allows us to adequately remove the pressure and arthritis that's compressive on the nerves. It also allows a little bit of distraction where otherwise it's difficult to release the pressure on the nerves and the nerve tunnels. It somewhat recreates the sitting position. And so that spring still allows for some motion, but it distracts the segment in order to open it up. So we both directly decompress the spinal canal and nerves, but we also indirectly, by having this spring, really hold the segment open to create create more room for the nerves, and it's still flexible and preserves motion. So it's really revolutionized my practice. It's generally per segment about an hour procedure that can be performed outpatient or with a minimal 23-hour stay, and recovery is generally 4 to 6 weeks. So again, shorter operative times, less blood loss, smaller incision. Really, we're seeing results similar to what we would see with these larger surgeries, but certainly with a less morbid procedure. Cervical arthritis, this is kind of a compilation of, again, similar to the lumbar spine. In the cervical spine, we can have discs, we can have the joints, we can have the ligaments, all causing compressive problems. Oftentimes, a presenting symptom is similar to sciatica. When it's a nerve that's being pressed, it can recreate in that distribution of that nerve a numbness, tingling. It can create weakness. Sometimes it's very positional. It's difficult to keep your head in an extended position because that presses further on the nerve. If the spinal cord, now in the lumbar spine, the spinal cord's already ended. In the cervical spine, the spinal cord is something that we have to be very cognizant of. The spinal cord we worry a little bit more about, or a lot more about, because it is, when pressed and damaged, it's hard to reverse that damage. The nerve has more of a healing capability. Unfortunately, the spinal cord does not. So when the spinal cord is pressed, the symptoms can be a little bit different than if the nerve is pressed. It can create more functional issues like coordination problems, so problems with fine finger tasks, problems with things like turning keys, twisting jars, or manipulating small objects. It can create a heaviness and a weakness, certainly in numbness. It can cause balance dysfunction as well. Really, a pressure up here in the cervical spinal cord can affect everything down below. Sometimes patients present just with numbness in their feet and legs. So it's something we have to really get a good history and understand a patient's complaints to be able to understand the pathology. And oftentimes we'll get into the diagnostics in a second, but we still try to treat non-operatively if we can. In a cervical disc herniation that's causing a nerve pressure, again, it's often something that will heal on its own a good 75% of the time. That's just with time and the body's remarkable ability to heal itself. A lot of times with those disc herniations, there's a lot of inflammation. So anti-inflammatory measures are important, whether it's medications, sometimes icing really helps, physical therapy with tractions, and again, epidural steroid injections as one of those more advanced measures to help calm down inflammation. Surgical approaches there's many options, certainly a last resort. But if surgery is chosen, fortunately, approaching the spine from an anterior approach is considered a minimally or less invasive option. When we approach the spine from an anterior approach, there really isn't any muscle. There's a very thin muscle that we have to dissect through, but there's a natural, wonderful plane that we can access and really see the discs well and take the pressure off. Oftentimes, once we remove that, we have to do what's called a fusion, where we take the disc out and put a spacer in to replace that. If we approach the spine through surgery from the back or from the posterior, it's a little bit more involved because we have to go through an extensive group of muscles that attach to the cervical spine. So there are minimally invasive options for the posterior approach to the cervical spine, and we'll go over some of those in a second. So the anterior cervical fusion is really the gold standard to treat cervical pathology. I generally tell patients that if there's an option to come from an anterior or front approach, then we'll take it, just because of the ease of recovery. Again, they're often outpatient. We're able to really access the pathology to see and decompress the nerves, to decompress the spinal cord, and really can make changes to alignment when appropriate. A posterior cervical fusion is often, it does take a little bit longer, quite a bit longer to recover from, but we're able to access over a longer, if there's more pathology spanning a number of segments, we're able to really access and to be able to treat a problem that's more extensive. From an anterior approach, we can go about 3 or 4 levels before we get we have a problem with healing. So, but from a posterior approach, we can span a real long segment to be able to treat the pathology. Of recent, over the past 15 to 20 years, motion preservation has really come into play. We really use the same approach as the anterior cervical fusion, but instead of putting a spacer back to fuse the segment, we put a mobile bearing back. And so a disc replacement in the cervical spine has really become a standard of care in situations where there isn't a significant amount of arthritis. Now, it really has to be just a disc pathology causing pressure on the nerve or spinal cord. There really can't be any arthritis in the joints. There really can't be a malalignment or something that could be also causing a problem besides the disc. So something that the disc replacement helps, one of the common issues with doing a fusion is that the biggest risk factor that we see in those patients is not so much the disc or the level that we treat, but long term, how does that fusion affect the level above or below? The change in the mechanics of how the spine moves can stress that level above or below and create early breakdown. The rate of this adjacent level disease is what we call is something that is a very significant issue that really in patients who have fusions we have to follow long term to assess if that is happening. A disc replacement can significantly lessen the chances of that happening. So in patients who fulfill the criteria, don't have a significant amount of arthritis, and it's more purely a disc problem, we're able to access that disc and to replace and still preserve motion. These are just some of the discs that are on the market. There's actually a few other FDA-approved disc replacements. One common question is, well, disc replacement, is that an option in the lumbar spine? It is, but the mechanics, the center of gravity, the stress on the lumbar segments make the disc replacement results a little bit less predictable in the lumbar spine. It's a less commonly performed procedure. In my hands, it's really one for a very narrow window of patient who doesn't have a significant amount of instability or pressure on their nerves. So it is something that really depends on the diagnosis. But in the cervical spine, we're seeing more and more commonplace being used for a lot of cervical conditions. So regarding the posterior approaches, there are motion preservation and limited access surgeries that allow us to still take the pressure off from a posterior approach, but allow us to preserve motion. So in a certain population of patients who have very bad, what we call congenital stenosis, where patients are born with narrowing of their spinal canal and pressure on their spinal cord, we're able to actually create an open window, we call it osteotomy or laminoplasty, that still preserves motion but allows us to just create more room for the spinal cord. So in patients who have primarily spinal cord pressure and issues associated with that over many segments, that's an option here that is proven to be great with regards to preserving motion, and recovery has been significantly shortened as well for those procedures. So again, motion preserving, quicker recovery, less blood loss, it's a great option that we have in a window of patients who have multiple segments of pressure on their spinal cord. Scoliosis is one we might not think has a less invasive approach. We fortunately do have options to address the discs in situations where there's significant contributors to a scoliosis problem. So scoliosis can be adolescent type, where it's something that's developed during the teenage years. The more common scoliosis that we see in our adult population is related to arthritis or disc degeneration. When a disc collapses and there's an asymmetry in that collapse, unfortunately it can create a scoliosis and curvature. Unless that curvature is addressed in the surgery, unfortunately it can leave an imbalance that can result in the future need of surgery or stress on the levels, again, above or below the surgery. So there are minimally invasive methods to be able to access the disc. we're able to correct, and those who've had experience or who have seen a spine surgeon or been told they need surgery, oftentimes the approach may involve an incision from the front and from the back. This procedure involves an incision on the side. The trade name is XLIF, or is a direct lateral fusion, where we're able to make an incision on the side that's very small. We use our tubular retractors again to really see the disc and remove and reconstruct that segment. So we're able to do it in a very quick time. It's a small incision, again, less blood loss equals shorter hospital stay, less narcotic requirement, all of these benefits of less invasive or minimally invasive surgery. So this is shows just the schematic of how it's approached, and we're really able to access the disc space through this window where there's minimal soft tissue disruption. The muscles really aren't damaged, they're spread, and we're able to see and really reconstruct that disc space. So this is schematics just showing intraoperatively the incision, our tubular retractors going in, and that's kind of our view. We use our microscope to really see through that portal, and we really can reconstruct using the X-ray and navigation to help guide us. We can remove the disc, take the pressure off the nerves, and really reconstruct the normal alignment of that disc. And this is a series of X-rays showing one of my surgeries where that disc was removed and that segment was reconstructed. Oftentimes, for the vast, overwhelming majority of treatment for scoliosis from a surgical standpoint would involve a fusion or reconstruction, where we realign the spine to its normal position and lock it in place. So, and this XLIF or lateral approach has really revolutionized our ability to do so. This is just a case example. On the picture on the left is a view from the side. The right of the screen is the front of the patient's body, the left is the back, and this is before the operation, so they have a significant kyphosis, or they're leaning forward. Doing this procedure at a few segments, you can see, and then actually, sorry, I reversed it. So on the left now is the front, the picture on the left. To the left is the front, and you can see how we really corrected that alignment, created a normal sway or normal lordosis. So a pretty powerful correction. It still involves screws and rods, but we're able to correct a major deformity through less soft tissue disruption, which makes recovery a lot easier. Kind of the newer, we're expanding on this technology, a relatively recent development, the being able to achieve an incision from the side and on the back in a single position, where we don't have to change positions during surgery, lessens operative time while still utilizing these minimally invasive techniques. So we're still expanding, still looking for ways to be able to achieve a reconstruction, to be able to remove any pathology that's compressive on the nerve and spinal cord, and doing it through smaller incisions. It really has and continues to evolve into the outpatient setting. So hopefully over the next several years, we'll see that transition from hospital to the outpatient setting. So again, I talked about this is on the left, the disc replacement in a lumbar spine. It's something we just have to be careful of. It was something that was thought of was great and was utilized quite frequently. It's less and less. We just have to be careful, even though it sounds great, it's not for everybody. The same thing with kyphoplasty or vertebroplasty, where a fracture could be treated with cement. It's a procedure that we used to use so commonly. Less and less, again, it's a procedure we have to really find the right patient for with regards to how the pathology looks and to how their symptoms are and the acuity of the fracture. Thank you very much for your time. We have some questions we'll answer here. Let's see. So question number one. Do you have or have you treated symptomatic Tarlov cysts, perineural cysts in the sacrum? It is messaged in my website. If not, is there any physician at Hoag that we would recommend? It's something that Tarlov cysts are very commonly seen, and the first part of the diagnosis is really working up to see, is that truly the pathology that's causing the symptom? Is it truly pathology that's causing the pain? Is that what really the problem is? First and foremost, looking at Tarlov cysts, whether or not they're erosive or whether or not they're creating any bone loss would be an indication that they're potentially causing problems. There aren't many surgeons that are routinely taking out Tarlov cysts. I've done some, but it's not something that generally it's been associated with another procedure by itself. It's not something that I generally recommend. There are centers, a few centers around the country that I can get you in touch with that are kind of the centers of excellence, so to speak, that I've seen patients and sent patients to that are very successful in doing so. But I have to say, out of all of the Tarlov cysts that I have come to my office, I generally find 80 to 90% of the time that's really the symptoms coming from something else. It's very rare for a Tarlov cyst to actually be symptomatic. But I have seen patients who, after the workup, we determined that the Tarlov cyst was causative, and they were appropriately treated and did quite well. How many segments can have the interlaminar stability device? Can it be used in discs that are compressed or crushed? So, great question. So the FDA approval is for 3, I think, contiguous segments. That being said, I've had a few patients where I've done 4. It's really between L1 to S1. So L1, 2, L2, 3, L3, 4, L4, 5, L5, S1. L5, S1, typically you can't put 1 in. So I've done 4. I think more routinely is probably the most common is 1 or 2, but 3 I've done a fair amount of, and a few 4s. And it can be performed in discs that are compressed or crushed. That's a good question. I think patients actually do better if they have a lot of compression. And if those discs are so compressed that the segments fuse, they don't do as well. So again, it depends on the degree and how collapsed that disc is. If there's any motion, generally if there's a little bit of motion there, patients actually do pretty well in my opinion, in my hands. What can be done for severe scoliosis? So, scoliosis, I treat a lot of scoliosis patients. Generally, a scoliosis is a problem when there's imbalance. The spine is this nice S-shaped curve, and so when there's an imbalance where the head is not over the shoulders, over the pelvis, over the ground, and there's progression there is when we generally indicate an intervention, and it generally involves surgery, particularly in the degenerative scoliosis population. So in patients who are healthy, relatively healthy, have good bone quality, have an obvious indication, surgery actually works very well for those patients. Patients with very severe scoliosis who don't have good bone quality do not do as well. It's just there's such a variation between patients. It depends on the evaluation. It depends on the symptoms. It depends on the degree curvature. Sometimes it's difficult in situations when the patient was older and has very severe arthritis that nearly ankyloses or fuses the spine. Is very difficult to correct into a normal alignment. If that combined with poor bone quality, it makes it very difficult to say that surgery would be successful. The challenge with severe scoliosis is it's very difficult to brace or to do conservative modalities such as therapy. But again, it's a relationship I have with a lot of patients. Just because I see a patient doesn't mean that I'm automatically thinking surgery. So if it's a severe scoliosis, and in fact, I try to look at any option but surgery. But it does take a lot of these criteria to add up to make a patient a candidate for surgery. But those patients who have severe scoliosis who we can treat, it's a lengthy and it's a difficult recovery, but those are some of my most grateful patients. So it's a good question. Last question, lumbar spondylosis, stenosis, scoliosis, and failed back surgery syndrome. Is there a minimally invasive option that might help? I mean, it's, again, this encompasses a lot of our diagnosis. I think about failed back syndrome, what that means. A lot of times in what I've seen, and I do a lot of revision surgery, it involves a problem with alignment, meaning that when the initial surgery was done, alignment wasn't factored into the equation. When we don't take alignment into account, when I say alignment, when we're talking about the lumbar spine, it really is recreating that normal sway and what your body or what your pelvis tells us that sway should be. If we don't perfectly correct that and we would do a fusion surgery that corrects you flat, it's really a setup for problems in a failed surgery. So in those situations, if there is a minimally invasive option, probably the most common one that we would utilize, and unfortunately, if it's a failed fusion surgery, it often would require a revision fusion surgery, but the most common procedure we would do in those situations, in my hands, involves that lateral technique. We're able to really access and correct an alignment very powerfully. But doing something that is a micro decompressive, something that is very minimalistic, it's a difficult one for me to say that would help. Again, it depends on the pathology, it depends on the symptom, it depends on the imaging study findings. So, it's these are the options, and this is kind of my bag of tools, but we got to look at your specific problem and look at what tools we would utilize to be able to fix the problem. And it's something that's not realistic. If it's something that's very difficult and the results aren't great, we're open and we discuss that very candidly. Thank you very much.